Okay, so I think the first message that I'd like to give you really relates to the patient experience. And patients are telling us now that the diagnosis of pemphigus is often delayed. So the International Pemphigus and Pemphigoid Foundation have surveyed their members, and they tell us that on average it takes 5 doctors 10 months to make a diagnosis of pemphigus vulgaris. And this is a focus of an educational campaign because they really want to raise the awareness of these disorders, because awareness is probably one of the key problems here. So I guess the take-home message is that if you come across a patient with persistent chronic oral ulceration, you need to think about the possibility of a diagnosis of pemphigus and then seek to do appropriate investigations to check the diagnosis out. Okay, so if this is a patient that's presented for the very first time, has never been on any treatment before, and if they've got extensive and aggressive disease, then I often start by treating them with pulse methylprednisolone, 500 milligrams on 3 consecutive days. The evidence base isn't good, but my own experience is that it can work very quickly to switch things off and turn things around. So I'll start off with that, followed on by oral prednisolone, 1 milligram per kilogram. And the adjuvant that I would choose in one of those really severe patients is pulse cyclophosphamide, given at a dose of 15 milligrams per kilogram. And you can use that straight off. You don't have to wait for any preliminary investigations like the TPMT level, for example, in azathioprine. And it probably works a little bit quicker than mycophenolate mofetil or azathioprine. You get a nadir in your white count at 10 days. So that would be my choice, and it's well established in the vasculitis literature. So pulse steroids followed on by oral steroids, 1 milligram per kilogram, and a pulse of cyclophosphamide, and that's what I would use to induce remission. And then to maintain remission, I'd continue with 1 milligram per kilogram of prednisolone. And what you're looking for is to get established healing. So this is something that's called the consolidation phase, and that's when you've got no blistering, you've got established healing, and you've got most of your lesions healed. And I'd combine that potentially with further pulses of cyclophosphamide. It can be given every 2 to 4 weeks, and that's, as I say, well established in the vasculitis literature. But if the patient has already responded really quickly, I might swap them at that stage to azathioprine. And then finally, what do I do to maintain remission in those patients? Well, continue prednisolone, but at tapering doses. And I would swap from cyclophosphamide to azathioprine because of the long-term concerns about the side effects of cyclophosphamide, the risks of hemorrhagic cystitis and bladder cancer. So swap to azathioprine, 2 milligrams per kilogram as the long-term maintenance immunosuppressant. So I think the role of rituximab is expanding, and in the future I suspect that it will become one of our main treatments potentially in the management of pemphigus. At the moment in England we work to an NHS England commissioning policy which was published in 2016 and allows us to use rituximab as a third-line adjuvant immunosuppressant. So initially you have to have tried patients on prednisolone in combination with azathioprine and mycophenolate mofetil, and if those two approaches haven't worked, then you're allowed to give rituximab after discussion with your MDT. Since that commissioning policy was produced, there's been a randomised trial produced from the blistering group in France, published in The Lancet in 2017, and that has shown some very impressive results for the use of rituximab. So it was a randomised trial. The intervention arm used rituximab in combination with oral steroids, and in the control arm, patients were given prednisolone only. 89% of patients in the rituximab arm achieved complete remission off therapy at 2 years. compared with 34% in the prednisolone-only arm, and that 55% difference is very large, and it's much more impressive than the results obtained from similar trials of azathioprine and mycophenolate mofetil. So what we need is more trials, ideally placebo-controlled trials, but my prediction is that we'll be using anti-B-cell monoclonal antibodies much more in the future, potentially as first-line treatments, and maybe one day steroids will be relatively historical treatments. Higher doses, you taper faster. So 5 to 10 milligrams every 2 weeks or so, down to a level of 20 milligrams of prednisolone. Then you start to slow off a little bit. So between 10 and 20 milligrams of prednisolone, we've suggested dropping by 2.5 milligrams every 2 to 4 weeks. And then once you're down to 10 milligrams of prednisolone, you go much more slowly in 1 milligram increments. And it's often convenient for patients to suggest to them perhaps tapering by 1 milligram every month. It's nice and easy for them to remember. One thing that's important to remember when you are tapering steroids and following up patients in clinic is that you must examine them carefully and check for any evidence of active disease. And that involves not just looking at their skin, but looking in their mouth, because often the mouth is the last site to heal and can be a barometer of whether you've got any active disease or not. So as dermatologists, sometimes people might feel hesitant doing that, but don't be afraid to do it. Have a look in the mouth, and if there is any sign of active disease, you need to be very cautious about continuing to reduce the dose of steroids, because there's a very high chance that if you continue to reduce the dose, the patient will relapse.